So welcome on for the first time. For people that aren't familiar of you or don't know about your background, can you tell us a little bit about yourself?
Yeah, I'm a physical therapist out in Bozeman, Montana. I've been working there for about 2.5 years now after finishing PT school down in Arizona. So I'm at a clinic called Build Physio and Performance where we see a lot of post-operative cases, primarily ACLs and lower extremities. We get to use a lot of fancy technology such as Humac Norm isokinetic dynamometer, some Vald force decks, and a bunch of other Tindex Mark 10s handheld dynamometers as well. I've been with the E3 team now with remote coachings for a year. I started in January of 2024 and actually did an internship with E3 back when I was in PT school in 2020 and 2021 and then joined the team at the start of 2024.
Yeah, you're at Build Physio, who we've had the owner on, Laura Obstedal, in a prior episode. So if people want to hear more about just the environment you're in and more about Laura, you can look back at our previous episode with her. Before we get started, I think it'd be great to just let people know about some of the wild training you've done. Can you just touch on I think there was that the powerlifting meet and the ultra or whatever back to back, and then that month of testing isokinetically or isometrically on the dynamometer. I think people should be aware of some of the freaky things you've done.
Yeah, so I have background in playing a bunch of different sports while growing up, and then realized I was a pretty mediocre athlete at all of them. So when team sports were done in high school and college, I got into powerlifting, became pretty average at that pretty quickly and stalled out, and went back to more of an endurance side coming from the team sports. And so I tried to just see how many weird things I could do at the same time. So while I was in PT school, I attempted to do a powerlifting meet on a Saturday, a marathon on a Sunday, and then a 50-mile ultra marathon the following weekend. The Sunday marathon ended up getting cut short due to very humid and hot weather in Chicago, but I ended up completing the powerlifting meet and the ultra marathon, and the marathon itself was cut down to 20 miles. And then shortly after I started working at Build with the isokinetic dynamometer, I wanted to get more comfortable on it. And when we were testing a lot of people and their test numbers would go up by a certain amount, I was always curious whether it was a real change to their strength or if it was just day-to-day fluctuation. So I ended up just testing myself on it every morning before work for 30 days straight. And I did an isometric test as well as two different speeds of isokinetic for a quad knee extension test and tracked that. So I do not recommend that because that was the most fatigue I've ever felt in one quad ever, even trying to do powerlifting and running things. So found out some good numbers. You need about a 5% change in things for it to be a real change, but definitely don't recommend trying it at home.
Yeah, one, how long did it take to just go through that whole process each morning? And then what was the biggest range, like the highest peak number and then the lowest throughout that period of time?
So the whole thing in it of itself took probably less than 10 minutes, especially I was comfortable setting myself up on it. It was a little awkward to adjust the seat while you're sitting in it yourself, but I was minimizing warm-ups at that time. It was just me by myself doing it. And then I'm just going to look at the poster right now. I believe my peak, let's see, I'm trying to look at it. I believe my peak isometric was in the 320 foot-pound range, and then I got as low as 270 isometrically, and then isokinetics were lower than that just due to the speed of the movement.
Was it mainly just like muscular quad fatigue you primarily felt, or was it a lot of like patellofemoral joint just discomfort and pain testing that intensely every day?
I didn't really have any joint pain trying that at all, but it was quad fatigue and then just overall central nervous system fatigue doing 9 maximum effort test reps every day for that long, along with normal training, was just taxing me overall.
Wild. I just picture like it's dark, you're in Bozeman, you see the lights on at Build, and then there's this guy just getting after it on the isokinetic with no one else in the clinic at like 5:30 in the morning. But we're going to change topics to the main conversation for today, which is on your article, Nate, that came out, I think, in October of 2024. So it's been a few months now, but I think it's a great conversation that the three of us are just gonna kind of riff on. And the name of the article, or was kind of a question of, should rehab be pain-free? And I want to hear why you wanted to discuss this subject and why you wrote on it.
So this is a common question, both not only in person in the clinic working with patients, but also with online consults with E3. It's a question patients often have of how much pain or discomfort should I be feeling? So we often have people who are terrified of feeling any sort of pain and viewing all pain as I'm doing damage to something in my body, and that means I should never be doing this movement or activity. As well as there's people on the other end of the spectrum who maybe more of the old school gym bro mentality, who are pushing through pain at all costs because no pain, no gain. And so it was a question I was answering a lot and explaining to patients. And so I thought it was a good idea to do a deeper dive in, make sure my own beliefs and explanations on it were accurate, as well as having a resource for people who I'm not meeting with themselves, but I can send this to them and they can understand, hey, some pain might be okay, but you shouldn't go 10 out of 10 pain every single session.
Yeah, you touched on kind of the two ends of the spectrum. There's that stereotype of people that just are kind of pushing through a significant amount of symptoms, and a lot of that kind of like bro culture, just kind of disregarding any level of discomfort. And then there's the end of the spectrum, which is, I think, thought of a lot of times in the rehab context, of completely avoiding all pain, or when exercising post injury, that you're inherently going to do more injury or worsen your symptoms with some level of discomfort. So we're going to dive into how do people navigate that from the patient and athlete side. As a rehab provider, how should we think about that? And then based off your article, I actually gave an in-service to our strength coaches, but I think it's super helpful for trainers and coaches as well, because they're seeing clients and people so regularly. It's like, how do you navigate this as well as someone who may not have a quote unquote injury, but has some level of just symptoms when exercising outside of the rehab context? So this is going to be kind of broad, but overarching in a lot of musculoskeletal injuries and conditions, Nate, what does the research actually suggest about pain and rehab and pain and exercise?
So obviously there isn't a perfect randomized controlled trial on every single possible joint or injury in the body and whether pain should be allowed with that. But there are a surprising amount of papers in different conditions looking at the comparison of keeping exercise pain-free with typically a lower load exercise and lower weight, comparing that to using a higher load, higher weight exercise and allowing some pain to occur during the exercise. And in general, it doesn't seem that allowing some level of pain is at all harmful or bad for the person. It's not necessarily any better for a lot of outcomes as far as pain, function, how quickly you get back to no pain or get back to your sport, but it doesn't seem to worsen symptoms or timeline to recovery. So it gives people a little bit of a choose your own adventure of how much pain you want to push into versus how much you want to stay out of, depending on your day-to-day activities or how your life is going at that time.
Yeah, so we're going to dive into a variety of different injuries and conditions and provide a little bit more specific conversation around each one. And then towards the end, we're going to discuss what are maybe some contexts where we shouldn't even have some level of symptoms, and how do we navigate that. Mark, let's start with tendinopathies or tendon-related pain. What does the research suggest? What is kind of your clinical experience trying to navigate tendon pain and tendinopathies and the kind of allowance of discomfort during the rehab or just training process?
Yeah, and I just want to add some other terminology because some people may hear it, but sometimes like avoidance coper versus endurance coper, those terms are used to describe this dichotomy of an avoidance coper would be someone who completely tries to avoid pain for fear of damaging themselves or making their condition worse. Whereas the endurance coper would be someone on that powerlifting spectrum or example that Nathan described, where they just keep pushing into pain and disregarding it and maybe actually prolonging their recovery or their rehab. But we don't have to use that terminology, but that's just something that you might hear. So in terms of tendinopathies, I would say that an article by Silbernagel et al. In 2007, and Nathan did write about this, probably really helped popularize the pain-based monitoring scale that we use today, or people often use. And that was originally based on a paper by Tomey in 1997. And he's actually the second author on that paper with Silbernagel. And really what they found, and what the research has found over the years, is that allowing people to push into some level of discomfort is fine with tendinopathies. Probably one of the most popular protocols that people are aware of is the Alfredson article in 1998, where it's like the eccentric protocol. And what they had people do is train at a certain, level of intensity or effort. And when training became pain-free or less painful, they would add more load to purposely make it painful. So I think the general heuristic in tendinopathies is whatever is tolerable for you. You're trying to get people to push high effort, high load, frequent bouts throughout the week. And as long as it's tolerable and they're recovering from that, it's usually fine. There's generally a few questions that you might ask somebody, and this might be true for all of the conditions that we're going to talk about, in terms of, is it tolerable during the exercise? So someone with patellar tendinopathy, they're doing a leg extension. Is it tolerable for them? And tolerable is unique to the individual. Some people or some physical therapists might give them a scale to use, like, hey, keep it at a 3 out of 10 or less, or a 5 out of 10 pain or less. But it's fine as long as it's tolerable for the person. Same thing you might see, like a stoplight analogy, where 0 to 3 is a green light, and that means go, and you can push as much as you want. Where up to like a 5 or a 6 is more of a yellow light, and it's still fine, but maybe you should exercise some caution. And then as you're approaching the 8s, 9s, and 10s, maybe that's more of a red light, and maybe you shouldn't push that hard. But I find that usually just telling people whatever is tolerable for you is fine. If they need a number, I help them try to discover what that number is for them that they're fine with. So that's the first thing. Is it tolerable during exercise? Then you would probably ask, is it tolerable after exercise? So let's say you exercise in the morning, and then you're doing your daily activities or your work. And if you have a spike in symptoms, that might mean that morning's training session might have just been a little bit too much. And then the last thing is, how was that person feeling the next day? So the day after exercise. And I think this is, really important. So going back, patellar tendinopathy example, let's say they do a squat or a single leg squat or a wall sit in the morning, and they rate their pain as a 3 out of 10, and they're fine with that. They do their exercise session, pain is tolerable. They go about their day, pain is tolerable. But then the next day, they say that their pain is a 7 out of 10 with that same assessment of a squat, single leg squat, wall sit, whatever it may be. Then we might think, okay, did something in that previous day or that previous day's training session contribute to this spike in symptoms? So overall, keep it tolerable during, after, the next day. But that's, a pretty simple heuristic that I use. I don't know if you two do anything differently.
Yeah, I pretty much keep it the same. And I like that you brought up those different ways to visualize it or explain it, whether it's the more of that, I guess, standardized or kind of typical pain monitoring model, or that scale of 0 to 10, 0 to 3 being this like quote unquote green or safe zone, 4 to 5 or 4 to 5 being acceptable, and 6 to 10 being excessive. But even there's a lot of gray and kind of blurred lines, or this more simplistic red, yellow, green light, or even more simplistic than that, is it tolerable or is it not? And that's such an individual person response. And like we said, some of these people that are pushing through symptoms, maybe we have to be a little bit more granular of, if we ask them if it's tolerable, they may say it's tolerable, but then you see them, gritting their teeth, shifting out of that tissue you want to load. Like, it's not a productive training session and stimulus, to where we have to have a little bit more maybe distinct barriers of what actually is tolerable or what we are looking for those individuals. Nate, any other thoughts for kind of tendon related pain before we dive into post-surgical?
No, for tendon related pain, that seems excellent. I do like the emphasis both you guys placed on making sure it's not necessarily just tolerable during the exercise, but also allows them to continue more exercise throughout the rest of the session, the rest of the day, waking up the next morning. All of that continues to be progressing as well, instead of I can add 10 more pounds to my knee extension reps here during the exercise session, but then I'm miserable in pain for the rest of the day, and I wake up the next morning in a bunch of pain as well.
And I just want to say, and we're probably going to talk about this with all of these examples, but you're individualizing this to the person, kind of as Nathan said. Whether you allow someone to have a 5 out of 10 pain, or they decide that they want to be fairly pain-free or a 1 out of 10 pain, it might not change the short or long-term outcomes that significantly. We'll probably talk about maybe the educational component with this, and why that's probably kind of important to allow someone to have some discomfort. But and I'll use this dichotomy here, if you do have somebody who's been completely avoiding pain and their function has been worsening and things have just been getting worse and worse despite them trying to remain pain-free, that's someone that you might encourage, hey, let's try this method of rehab and see how it works. Something a little bit different, versus somebody who's continuing to push into high levels of pain because they have a high pain, they say I have a high pain tolerance and they just want to continue what they're doing. That might be someone that you have to pull back a little bit. So we're giving these broad examples as it relates to diagnoses or surgery, but you'll still have to individualize this to each person that you work with.
And I think this next area, the post-surgical, is a good example of that, where, and Nate, you can go from here, but where someone's saying that these exercises, this amount of load is tolerable, but then you're seeing things post-operatively that you may not feel comfortable with, increased levels of effusion, more of an antalgic gait, other things that are giving you, that yellow or green light, hey, we need to pull back for a variety of reasons. But let's go broad post-surgical. What are your thoughts with level of symptoms and pain here, Nate? And does the surgery, let's keep it musculoskeletal, but does the surgery type or body region change your answer?
So as a general topic, I think post-surgical patients are ones that it's warranted to be more conservative with pain in, especially depending on the type of surgery. So if it's a very large surgery or a very large repair, such as a rotator cuff repair, meniscus repair, Achilles, quad tendon repair, those are ones where we know there is definitive specific tissue damage that needed to be repaired during the surgery. And so it is warranted then to protect that tissue to allow the biological healing to be occurring instead of pushing into pain and potentially risking the repair itself. Another one that I see a lot with our clinic is ACLs. So with ACLs, if you have a younger population, they're typically doing an autograft where they're taking a portion of your own body to be your new ACL and causing trauma and tissue damage to that portion of your body, typically a quad tendon, a patellar tendon, or a hamstring, where they took the graft from. So you have to not only rehab the ACL, but you have to be mindful of the graft site as well, because that has damage and we're trying to protect that and rehab that. So the common one with, say, a patellar tendon graft is you're essentially developing a really bad case of patellar tendinopathy, but with likely more actual tissue damage than in a true patellar tendinopathy. So patients doing, say, a knee extension after a patellar tendon graft will have a lot of pain at the graft site, and we have to monitor that. So we typically won't, for the first 8 to 12 weeks, allow much, if any, pain at that graft site. And then as we know that that is healing and becoming more structurally sound, we can start to push into more pain. And that's when we go into more of the tendinopathy guideline as we're further out from surgery, where as long as we're within a 3 or 4 or 5 out of 10 and it's getting better the next day, we can progress full speed ahead.
A question with that, Nate. If let's keep that example of the patellar tendon graft. If they're having some level of just like diffuse or just anterior knee pain, but it's not along the donor site, are you all more okay with that? Or does that still kind of similar guidelines?
I'm typically more okay if it is just general knee pain, especially when it is early out after surgery, if they're 4 weeks out after surgery. The fact is they went through a big trauma to their knee. And so there's going to be some level of pain and soreness associated with the fact that you had a surgeon go into your knee and reconstruct your ACL. So there are specific sites, such as graft sites for patellar tendon or quad tendon graft, where I'm more cautious pushing into pain with that. Same thing if someone had a medial meniscus repair and all of a sudden we're doing an exercise and they're pointing directly to that medial joint line where their pain was before surgery and starts complaining of symptoms there, I'm typically going to back off from that. Versus if they're talking after a medial meniscus repair about just general patellofemoral joint pain, I'm going to be more okay pushing into that a little bit there.
What about the knee replacement or hip replacement situation or context? Mark and I, we had a prior episode on knee replacement, and my overall kind of view or take is, especially with like regaining knee flexion, I'm a little bit more liberal of how much pain someone can kind of allow, and it's just this assumed this is not going to be really comfortable. But what are your thoughts there, Nate, with more of these arthroplasties or hip or joint replacement surgeries?
So these are ones that, if you understand the surgery itself, the fact that they aren't reconstructing ligaments or tendons or muscles at all, they're replacing the bone for the joint for a knee replacement, for example, that surgery is structurally sound, and we're needing to push into pain to regain the function of the knee, especially like you were talking, the knee flexion range of motion there. It's a risk or reward. The risk of messing up a knee replacement surgery when you're doing passive knee flexion range of motion 3 or 4 weeks out from surgery is really low, but the risk of not getting that knee flexion range of motion back and having prolonged deficits from that is a lot higher. So that's one where I'm a lot more comfortable pushing into pain there. And it's one that's really important for the patient education aspect, both hopefully from the surgeon as well as from the PT. Hopefully you see them preoperatively or even the first couple visits postoperatively, setting the expectation that this is not going to be a super comfortable, pain-free rehab. We're going to have to push into some pain to get your range of motion back. But if we don't do it now and get it done now, it's going to be a lot worse long term. That is one of the few post-surgical cases where there is a little bit of research looking at how much pain is allowed in it. There were 2 systematic reviews by Kanyu et al. In 2023, just comparing different rehab programs for hip and knee replacements. They didn't get into the specifics of the different programs as far as how much pain exactly was allowed, like other studies have for subacromial pain syndrome, but we can venture a guess that if there's different focuses in the different rehab programs, there's likely going to be different amounts of pain during those exercises, and they found no major differences between programs for both hip or knee replacements.
I think this is a good example too, in which it's activity dependent. So you're both given the example of allowing pain during regaining knee range of motion after knee replacement. And it's very important to regain that knee range of motion. And it's going to be uncomfortable most likely. And if you don't get it early on, it's harder to get later. And it's going to be more uncomfortable more likely later on as you try to regain that range of motion. But the risk of harming that implant is very low with what Nathan's describing, versus if someone decides to ditch their walker or their crutches and now they're weight bearing on this implant and it's really painful and their knee is getting swollen. Like, there's different types of discomfort that maybe we're comfortable with, because the knee range of motion, you're not really impacting the joint all that much. But if someone's walking and they're like, oh yeah, it really hurts, but I can kind of tolerate it, you might say, okay, let's find this balance of using your assistive device, making sure it's comfortable, et cetera. So even within a person and within a specific diagnosis or category here, it can be kind of context or activity dependent as well. And I think using the framework of, well, are they having more joint diffusion? Are they having this antalgic gait? Is their function actually worsening? Kind of helps guide the rehab as well.
Mark, in the hip replacement context, so for knee flexion, that's primarily what we were discussing for a total knee replacement, but for a hip replacement, does that change with that level of kind of comfortability with, hip extension or flexion or ER range of motion and kind of pushing into some level of discomfort? Is it less of a priority? What are your thoughts with the hip?
To me, pushing into discomfort purposely after a hip replacement is less necessary. I don't think trying to regain hip range of motion is the same as trying to regain knee range of motion after a knee replacement. And I think a lot of people just improve their hip range of motion like naturally after the surgery without having to do anything because of this implant. I would say I have been considering it for myself. I'm my own case study of long-term is allowing some discomfort during training a good thing to it ensures that I'm pushing hard enough that even if I do have a little bit of discomfort, maybe I am loading the bone the way that it needs to be loaded, because that is a problem after, joint surgeries, is that there is going to be bone loss over the long term. And that, that's what often leads to these revisions and things. But yeah, short term, I don't really see the need to purposely push into discomfort, especially at the hip too. If someone does have a flare up, then it does kind of lead to that antalgic gait that you described. Same thing. I don't know if you guys have a different thought process there.
No, I think I'd be on the same page. Nate, any other thoughts or things you want to touch on for post-operative cases?
I think the one last condition that I should mention is after any sort of traumatic fracture where they're putting a plate in or a rod into, I see a lot of tibial fractures in my current clinic, and there is often some level of discomfort there long term at the spot. It's extra tender if you're pushing on it, or it's always going to have a little extra soreness the day after if they do a really long hike or they go back skiing or snowboarding or jumping or playing basketball. There's likely going to be some level of discomfort there. And so educating them on that, hey, you have some structural integrity with the surgery, the bone is healing, there's some soreness there, but we aren't refracturing the bone or doing anything like that. And being upfront with that, especially as they're leading into that phase of rehab where they're going to be encountering that, is important in my opinion.
Okay, I'm going to dive into some of the shoulder pain topics. Again, Nate, this was in your article, but subacromial shoulder pain, rotator cuff related shoulder pain, this kind of umbrella term for anterior shoulder pain, where the specific tissue involvement may not matter a ton because it may not change treatment. We've had a ton of guests on prior episodes discussing this topic of rotator cuff related shoulder pain with Adam Meekins, Jared Powell. We've talked about some of the kind of the debunking of like thinking that with some level of discomfort or some of these positive orthopedic tests that we're creating further damage or kind of shoving the parts of the tissue into the bone with this impingement. And similar to these other scenarios or cases where they've done different research studies looking at some level of symptoms during rehab or working into or loading a specific movement or pattern with discomfort versus avoiding pain, there's really no worsening of outcomes, and it just provides confidence and reassurance to the clinician and to the patient that it's okay to have some level of discomfort and that we probably shouldn't avoid a lot of these positions just because there's a little bit of pain, and educating on, this doesn't mean that you're worsening your rotator cuff tendon pathology, or if you're exercising with an MRI confirmed rotator cuff tear, that doesn't mean when you have symptoms, you're actually worsening the progression of this tear. And just reassuring that we want to keep the surrounding tissues and that tissue as kind of resilient as tolerable, and maintain and improve the strength and the motion, as opposed to just limiting it. So that's kind of the rotator cuff related shoulder pain and subacromial pain discussion. Other shoulder condition, big one is frozen shoulder. Again, we've had other prior guests dive into this topic. Philip Strauff, more recently, I think episode 140, and then a group of other researchers a few years prior, I think it was episode 68, but similar concept where, well, different in the sense that there may be significantly more pain, especially early on, and there's these different kind of phases of frozen shoulder, but knowing that we need to eventually work through and work into some of these restricted positions, and it's assumed that there's going to be some level of discomfort, but it's not going to inherently worsen your frozen shoulder. This is going to take a really long time, and if we completely avoid any position or any activity with some level of shoulder discomfort, it's going to be even more limiting for an individual throughout the year or two plus that someone may have frozen shoulder. So having some level of kind of graded exposure and graded mobility in those positions, knowing that time itself is going to be super helpful, and continue to train the surrounding tissues and the positions someone can tolerate is major. Another area that I don't think, Nate, you touched on in the article, but I'd be curious to hear y'all's thoughts. So we have kind of the stiff shoulder, we have the painful shoulder, and then we have the unstable shoulder. Some of these, dislocations, recurrent subluxations. What are y'all's thoughts in regards to, do we allow some level of symptoms when someone's had a dislocation or, recurrent episodes of dislocation, and they haven't gotten, a tightening procedure, they just are coming in for non-operative management? My personal bias is I'm still okay with some level of discomfort, but when it comes to an apprehension sensation or a feeling that someone's shoulder is going to come out of socket or going to dislocate during exercise, if they're that kind of hesitant or guarded, or they're describing that sensation, that's something I'm more conservative on and want to be, have a little bit more strict rules about. But Nate, we'll kind of start with you. Do you have any thoughts on more of the unstable shoulder and how to navigate that kind of pain experience?
I think I have very similar thoughts to you, as in I'm a lot less likely to push into the feeling of potential dislocation or apprehension with an unstable shoulder and any symptoms such as that. I'm okay with some level of discomfort and pain, especially if I know it's in a position where functionally the shoulder is at a lot less risk in order to dislocate. And so if they often have an unstable shoulder, they might have some muscle weakness or joint laxity there that we can address through different exercises, strengthening all the muscles around the shoulder there. And so if it's in a safe position for that, I'm a lot more willing to push into some discomfort, but I'm going to be avoiding those apprehensive positions and taking a much slower graded approach to expose them to that, if that's even something that they need to do long term.
What about you, Mark?
Yeah, I would also try to minimize the apprehension. To me, I think about it as trying to set a record for the longest time they've gone without having a subluxation or dislocation. So they come in and you ask them, okay, when's the last time you had a dislocation? They say 3 months ago. And then you ask them, okay, what's the longest span of time that it's been like between dislocations? And they say, let's say 3 months. Then in your mind, you might say, okay, I'm going to try to set a record here and go for 4 months, no dislocation. Okay, now 5 months, now 6 months, right? So you're probably better off trying to minimize that apprehension. And then, as Nathan alluded to, you're doing slow, gradual progressions and just seeing how that apprehension and their tolerance improves over time, and considering what's realistic or necessary for their long-term goals. For the rest of the shoulder, I have a couple of thoughts. So one, I think education and communication is important here as it relates to prognosis. So someone like who has frozen shoulder, you might have to educate them that you're doing the right thing by allowing some level of discomfort, and regardless, this is going to be a 1, 2, 3, it's going to be a long process, couple of years potentially. And so trying to build that trust in that sense. I would also say as it relates to communication, we have qualitative studies about what people think is happening in their shoulder when they're given the diagnosis of something like shoulder impingement. And so this is a question that you can ask for any diagnosis, because you might be really surprised about what you hear. So if you say, hey, when you experience shoulder pain, when you lift your arm out to the side, what is it that you think is happening? And they might describe, well, my rotator cuff tendon is getting pinched and it's tearing every time I feel that pain. And then that's an opportunity for you to have a discussion with them and say, well, actually, that's probably not what's happening, and maybe build some buy-in there. I remember I saw somebody who had a lumbar fusion, and then it failed and they had another surgery. But when I asked her what she thought was happening every time she had pain or these, different nerve sensations, she just went back to thinking about like what the doctor had told her in terms of that fusion failing, and just thinking that there were pieces of metal kind of floating in her back, stabbing at her nerves in the lumbar spine, right? Even though she knew that that wasn't happening, that's just the thought process and like the visualization that she had. And so even though we talked about it, there was nothing I could do that was going to change her mind anyway there. And then I think the other thing is, for all of these things, like the best way to get patient buy-in is to have probably good results. If you tell somebody, hey, we're going to use this pain monitoring scale and we're going to work through this over the course of 3 to 6 months, and they're starting to see improvements after 6 weeks, and prior to that they haven't been improving for 3 months, that's a great way to get buy-in, right? Just doing the right thing, gradual progressions, is always going to get more patient buy-in than any amount of education and communication.
Nate, let's go back to, what about patellofemoral pain? We kind of touched on it briefly with if someone has just anterior knee discomfort with postoperative ACL compared to the donor site. But what does the research suggest, and what is your recommendation for someone managing patellofemoral pain?
So this patellofemoral pain is actually where the original article describing a pain monitoring system came from at all. Mark alluded to it a little bit earlier, but it's by Roland Tomey in 1997, where he had a couple groups with patellofemoral pain, and he just compared isometric and eccentric exercise training, but with the very strict guidelines of pain up to a 2 out of 10 is safe, up to a 5 out of 10 is acceptable, and anything above a 5 out of 10 is, in his words, high risk and was to be avoided. And this was with the acknowledgement that pain should subside by the next morning. And he found no differences between all of the different forms of training with that monitoring system, as well as good results as far as pain and function long-term with all of those patients. So this is one where I think we've gone through this idea with all these different topics, but education is important. So explain to the patient, hey, these are the different exercises that could load your knee a little bit more and are likely to cause more discomfort. So if it's something where your knee is really flared up and you don't want to be causing more discomfort, we should probably back off from those and maybe sit back in a squat and use your hips a little bit more. Versus if things are feeling good, you're on the up and up, these are ways we can progress it by doing a more knee dominant lunge or doing more knee extensions, stuff like that. But this is one where, unless they have a very confirmed and very significant tissue damage and it's very much in line with their exact symptoms, if it's just overall patellofemoral pain, this is one where I'm a lot more comfortable going into some pain, as long as that's something that the patient themselves is willing to do, like we talked about before, of the patient's specific needs for all of this. And if someone's been avoiding pain for a long time, we might want to push into it a little bit more. or if they've been pushing into pain and staying really flared up, it might be worthwhile to pull back from it.
Mark, let's go back to you. Going back to the knees and the hips, knee or hip osteoarthritis, or just OA more generally, managing symptoms with knee or hip OA?
Yeah, I think we kind of touched on the important points that relate to this. Keeping it tolerable, making sure that you're not increasing effusion or an antalgic gait. And then communication and education is really important here, because I think a lot of patients do associate osteoarthritis with just this pure kind of wear and tear type disease progression, in which any type of pain with loading means that they are worsening their joint. And so it can be helpful for them to know that pain with OA can wax and wane. So there might be times when they have more pain, there might be times when they have less pain, but same thing, we're just trying to determine tolerable levels of activity and making small gradual progressions over time.
An acute example or topic that we haven't talked about yet is, let's say, acute back or neck pain. I think I can start, but I'd love to hear y'all's thoughts. As long as we've ruled out the concerning things, but we think that this is kind of an isolated incident, or, you know, someone's had episodes in the past, but it's localized neck pain, mid back pain, or low back pain. I think all of these still kind of principles that we've already discussed apply. Going back to Mark's point about some of the just discussion and patient education, discussing the kind of average recovery timeline or how long this may take, reassuring that it's okay to move, temporarily pulling back on some of the aggravating activities in this really acute period, but kind of emphasizing that we don't want to completely be bedridden and be as sedentary as one may think to protect, and kind of push them to resume normalcy as much as they can with the modifications that are necessary to kind of get through the days and weeks during this acute flare-up. And then the other example is kind of a radiculopathy situation with, you know, either lumbar or cervical radiculopathy, where there's other things that are just not localized to the back or the neck. You have symptoms going down the arm or going down to the leg. You may have some diminished sensation. You may have some motor weakness. In those contexts or circumstances, would y'all's kind of kind of discussion around symptoms change? I think in, you know, my perspective, and I think about the conversation I had with Aaron Kubal maybe a year ago, but like maybe not working into a ton of reproducing of some of those symptoms, like stretching or exercising into those positions that really spike up kind of radiating or radicular pain, because it just seems like it's not worth it. But do you all have thoughts when it becomes more of this radiculopathy context as opposed to just localized acute low back or neck pain?
Well, I would differentiate subjective from objective things a little bit there. So if somebody has this lumbar radiculopathy and, you know, you test their ability to do heel raises, and on day one they can do 5, and over the course of 3 months they can do 8 or 10, and then you tell them, hey, you know, go ahead and do whatever, push as hard as you want, train however you want, and then 3 months later they're back to 5 out of 10. Like, there's this objective weakness that's associated with the lumbar radiculopathy. That's an example where, you know, I'm not trying to push into that, and that's a good measure of progress of nerve healing, right? Is how is that muscle strength or weakness changing over time versus just like, oh, do you have some discomfort? Might be a little bit different conversation.
Would that be similar for, you know, altered or diminished sensation if they are reintroducing exercises or specific positions where they have this kind of base level or average level of change in the, you know, sensation of the leg, but as we introduce more, it's actually worsening? Is that kind of similar to the motor or muscle strength context?
Yeah, and I think that applies to any of these conditions, right? Anything that's worsening over time is is probably an indication that you need to redirect your approach a little bit. So, yeah, if they have some baseline paresthesias that occur with certain movements and activities, and it's something that they do on a regular basis, they're just, walking to and from wherever, that's fine. That's understandable. We're still going to track it and ask them about it and see how that's changing over time. But then if you introduce activities or exercises that, now their foot is feeling numb completely by the end of that walk and before it wasn't, then you might just need to rethink the approach.
Last one before we shift gears and go into contexts where we want to minimize or completely avoid symptoms, strains and sprains. So this is one that has quite a bit of research, and maybe Nate, you can start with it, but the classic hamstring strain example, or something like an ankle sprain. What are some, with these acute injuries, strains or sprains, what does the research kind of suggest? And clinically, how should we kind of go about managing those acute symptoms and injury?
So the classic paper on any sort of muscle strain was by Jack Hickey in 2020, looking at hamstring strains for, I believe it was soccer players, and comparing just completely pain-free rehab to allowing up to 4 out of 10 pain during rehab. And it was a good rehab program that they laid out, where there's a lot of progressive strengthening, exposure to running. And with that, they found no difference in return to playtime, strength, or re-injury rates. So I think it follows a lot of the same ideas we've been talking about this whole time, where if you're okay with some pain, it's not the end of the world. We can continue to progress exercise, but it's not something that you need to be doing. With muscle strains and sprains, those often occur in probably a more athletic and sporting population than your average sedentary person. So if they are playing a team sport or are training for a marathon or something like that, it becomes a lot more of a shared decision-making idea, where if it is a professional soccer player who's coming back from a hamstring strain and their performance is there, but they're still feeling some pain or discomfort, it all depends on the context of the season and the team and everything like that. So it's ideal to have the full contingency of whoever's involved in the sporting context and all of their opinions and values placed into that as well.
I think that's a good point, because a lot of the rehab I think that we're probably all thinking about and describing right now is done in a very controlled environment. And, Nathan's describing return to sport. And so let's say acute ankle sprain, you allow some discomfort. There's no progressive worsening of function, swelling, effusion, etc. But then you get them back on the soccer field. Depending on the timeline and how far they are into their rehab, they might be at a higher risk of re-injury because of their previous, ankle sprain. So because it's a less controlled environment, there's a lot more things going on, whereas everything else that we've talked about, regaining knee extension range of motion or whatever it may be, is a little bit more controlled environment. So yeah, I just think that's something to think about, especially if pain during those sporting activities is also causing you to change the way that you move or react, or there is even a fear-based component to it. It's just a consideration. That's a whole nother conversation, but
let's switch gears and go to times and contexts when pain should be completely eliminated or minimized. Nate, I'll let you start. What are some examples here?
So I think I touched mostly on one of the examples in the past about postoperative conditions, massive repairs, anything like that. So I won't review that again. But I think another one worth considering is any sort of bone stress injury. So whether it is a stress reaction or proceeds to a full stress fracture, those are ones that we typically want to be more conservative with, as we know there is actual bone damage that is causing the pain and is going to be progressively getting worse if you are continuing to push through pain with that. So that's one where, especially if they're having pain, say, in their tibia and their shin with daily walking, and they've been diagnosed with a bone stress injury, then that's one we probably not either put them on crutches or put them in a boot to decrease the pain there. And then also progressing into rehab, we need to be addressing all the other multidisciplinary things, such as making sure their nutrition and psychology is addressed. But then with exercises, it's one going to be more cautious with progressing there, especially when they're returning to running. If it was, say, a cross country runner there, they're often going to have some sort of discomfort in the same site, but it is one compared to a tendinopathy where we're willing to push into a 3 or 4 out of 10 pain often. I'm not wanting to push into a ton of pain or discomfort there. And so if they do say they have pain when they're, say, on their first 10-minute run after recovering and they have the 3 out of 4 pain, I'm going to pull back, slow down their rehab, and build back up a little bit slower the next time. So we know we don't want to have a reoccurrence, which is unfortunately relatively common in bone stress injuries.
Yeah, and we had prior conversations with Steph Munt and Chris Johnson and Nate Carlson diving into this extensively. So if people want to learn more about it, they can go to those resources. The bone stress injury, the post-operative specific scenarios, anything else, Nate or Mark, where you're cautious or limited with pain during training or rehab? I think, an example is just an acute situation where you're concerned about, a fracture. Like, let's say someone comes in, they think they may have an ankle sprain, Ottawa ankle rules, they can't even bear weight, it's so painful. That's a situation where I would probably want to limit exposure to loading on that site until we can either rule in or rule out a fracture. So some of those immediate kind of acute management situations, but outside of that, anything else that y'all would consider or that we haven't really touched on?
I think anything where there is, you have to consider the integrity of the tissue, and is whatever you're doing potentially going to, harm that or potentially make it worse. I think that's what we're considering. And I would say for all of these things, like, I don't take the approach that the Alfredson protocol did, where it's like, oh, you have no pain. Well, let's find that pain and use that as our progression. It's, if someone can get through rehab with minimal to no pain and they're working through the progressions and the exercises and the activities that we've come up with together, that's fine. Like, if someone gets through rehab with a 1 or a 2 out of 10 pain the entire rehab process, no problem. If somebody else is a 5 out of 10 the entire process, no problem. I don't think any of us are taking this like no pain, no gain approach where we're purposely searching for and striving for pain. So hopefully that doesn't get misconstrued either, that like rehab doesn't have to be, overly painful or uncomfortable either.
Something that we haven't discussed, and Nate, you didn't bring up in the article, but what commonly is people experiencing persistent widespread pain. We had prior guest Derek Griffin discuss fibromyalgia, and I did an article on it, but situations where someone's lived with chronic persistent pain, maybe throughout their whole body or specific area, outside of some of these kind of persistent contexts we've already talked about, tendinopathies and OA and others, but someone says, I live with a 5 or 6 out of 10 level of pain. How do you all manage those contexts where they're already at this heightened level of symptom irritability and limitation? I guess my initial framework or thought is we're still going based off of your average and your baseline, and we don't want to push extensively beyond that. But your kind of normal is, let's say, a resting 6 out of 10. Okay, that's where we're starting. And we know that we're not concerned about these acute tissue pathology or worsening of injuries. So we can, again, even though we're on that typical scale of we're in this yellow zone, this is a different concept for someone that's experiencing widespread body pain or fibromyalgia. But do you all have any ways you would discuss that with someone who gives either that pushback or just that explanation of like, well, I'm living with chronic pain all the time. How do I manage that?
So I think I like your approach a lot of using whatever their baseline is as the baseline that you're monitoring change from. So if you're starting at a 5 out of 10 pain and it goes up by 3 or 4 digits, that might be in that yellow light range where instead of the yellow light being a 3 or 4 out of 10, it's just a 3 or 4 up from their baseline of a 5 out of 10. The other things I like to consider in those chronic pain conditions are asking what their goal is. So, is their goal solely to completely get out of that 5 out of 10 pain and bring it down to a 1 or 2 out of 10? Or are they comfortable with that 5 out of 10 pain for long term and they care more about improving their function while keeping the pain the same? So I kind of describe to them two different scales or metrics of they have both the pain and the function. And so if the pain's staying the same and the function's going up, that's progress. Or if the function's staying the same and the pain's going down, that itself is also progress there.
Mark, do you have anything to touch on there?
Yeah, I would just say that the building of trust is important here. You know, like, yeah, whatever pain they rate it at, and let's say you are working on some kind of functional or activity-based goal, you have to be mindful of the progressions that you do, because if sometimes the flare-ups are a little bit less predictable. And so, you know, making sure that you're doing reasonable progressions and just, yeah, you know, if you have somebody like that who has an extreme flare-up, and it takes days or weeks or longer to resolve, it's hard to build trust there. And like Nathan said, it's also hard if someone comes in and you ask them, hey, what are your goals? And they just say, I want less pain, or I want to be pain-free. It makes things tricky.
Anything else before we wrap things up, Mark or Nate? I thought this was a great discussion. We obviously went through a list of variety of kind of injuries and context, but hopefully this gives patients and clinicians and just anyone listening a better understanding of how to navigate this in the clinical context in life and exercise. But either of y'all have any final thoughts or things to touch on?
So I think as a big summary for the rehab clinicians out there, I kind of viewing this as three different parts. We need one, a very good understanding of anatomy and pathologies to determine whether it is something that we can safely push into pain with. You had a great example of if we're suspecting a fracture or we're bone stress injury or post-operative cases, we need to have a solid understanding of tissue-based, is this safe to push into pain? And then we need to do a really good job on patient education and explain to the patient what we're looking out for, what variables we're tracking, if something is safe to push into pain, and if it is, why is it safe to push into pain as an explanation for them. And then the third thing is knowing exercise progressions and just overall movement and life progressions and ways to alter things to progress things and move them forward, or if something is getting really flared up, how to regress that and move it backwards to stay a little bit more pain-free if that's what's indicated.
Crushed it. Mark, you have anything to add there? Nothing.
No, I was going to make some kind of joke about being, bulletproof or pain-free for life, but no, yeah. I'm good.
Sick. Well, Nate, thank you for coming on and for writing this article. We'll link it. There's a few others that I think will be helpful. Mark, I think you had one 2 years back on like how to adjust training in the context of pain, and that gives just also kind of practical examples of things to modify. And then I may also link the Goldilocks article and probably our prior context podcast, because I think that's helpful as well. But Nathan, Mark, we'll call it there. Thank y'all.